Malnutrition in the elderly is really a big issue. You find it everywhere. You find it in the community, you find it in nursing homes, and you find it also with a high prevalence in the hospitals.
In the nursing home, we see it being at about 50% in some studies.
There's definitely a wide under-recognition in the field. We need more resources. We need more training. We need more interest among those who provide the care for older persons. We first should focus on the aging process. If you look at persons that are beyond age 80, they have underlying changes of pathophysiology. We have a decrease of appetite, we have a decrease of hunger, increasing satiety postprandially. So we have age-associated changes.
We have issues with functional status, so that if older adults can't get around and shop to buy the food that they need, and they can't cook the food that they need, they may have a decrease in their actual dietary intake. They may have functional impairments. They may not be able to actually feed themselves.
If you have a drop of functionality, if you have a loss of independence, there's a close relationship with increasing malnutrition. But of course there are other comorbidities like dementia, like depression. Depression is the single most important origin of becoming malnourished in community living older persons. To my mind, we have very, very serious and very reliable data on the association of malnutrition and mortality in very different settings. So it's very, very clear for older persons, mortality is increasing steeply with declining BMI. So malnutrition, it's really a deadly disease.
If older adults have malnutrition and they're hospitalized, we know that there are some studies that show that there's an increased length of stay.
It's about staying longer in hospital, having more complications, having a drop of immune competence, which might be very important in the acute setting. If you decrease intake of energy and protein, you lose muscle mass, you lose muscle strength, and you lose independence. So it's very, very important for having a healthy aging community. There's a large misunderstanding. Many people still think, and colleagues do, they think losing weight in older persons is destiny. It has to be, but it's not true. And it's often not associated with malignant disease. There are curable diseases that stand behind losing weight, like endocrine disease, GI disease, depression, and so on. So you can do something about this, but you have to look at it, and you have to look at the causes of becoming malnourished.
All older adults can be at risk for malnutrition, so it's really important that we screen everyone and screen them across all types of settings.
If you want to tackle malnutrition in older persons, you have to have a systematic approach. And screening helps. It's a common phenomenon, so it's worthwhile looking for it, and you have to do screening to really recognize those that are affected or that are at risk. And screening tools really help. They are necessary in this setting. The mini nutritional assessment, the MNA, is so important because it really focuses on the older population. It includes the analysis of their way of becoming malnourished, like becoming cognitively impaired, like becoming depressed, like losing functionality, like having changes in their oral diets.
Well, the mini nutritional assessment has been validated in over 400 studies, so that we can use it in older adults living in the community, we can use it in older adults living in the hospital, or in rehab settings or nursing home settings.
We have more validation for this tool than for any other tool applied in older populations.
The short form is the first 6 items of the mini nutritional assessment, and it's the screening component. It's very, very simple to use. Any healthcare professional can conduct the short form mini nutritional assessment. Has your food intake decreased at all in the last 3 months due to maybe a loss of appetite, difficulty chewing, or any GI or digestive problems?
Well, I was a patient in the hospital, and
And so if you think back to over the last couple of months, maybe the last 3 months, have you lost any weight?
When I was in the hospital, I did,
Okay.
but now I'm back to normal.
And I see that you were able to walk into the exam room,
Yes.
so you have no problems
No.
getting around. Have you gone back to driving yet?
About 2 days.
Okay, wonderful. So you have no mobility issues and you're able to get up and around. Now you've had your knee surgery 3 weeks ago. Have you had any other issues? Have you any other illnesses or happening
No.
to you? Any psychological stress? Have you had any bereavement or any
No.
moving issues, relocating?
No.
And have you had any problems with depression or any feeling sad or any emotional problems recently?
No.
Okay, wonderful. Of the first 6 items on the mini nutritional assessment, probably the most difficult would be body mass index, because you need a height and a weight and you need to calculate that, convert the height and weight into the BMI. People lose about 2 centimeters of their height over time. So it's very important that when we calculate body mass index, that we have an accurate height. So if a person cannot stand erect and you still need to obtain an accurate height measurement to calculate body mass index, you can do it in 2 ways. You could take the demispan measurement, and all you need to do that is a simple tape measure, or you can take a knee height measurement. And we put that into an equation, and we can get then an estimate of their actual standing height. What we're going to do now is show you how to take a demispan measurement, raise their arm, and the only thing you need to do is actually, for landmarks, is find the mid-sternal notch, put an ink mark there, and you take your tape measure from the mid-sternal notch. You have them extend their left arm so that it's straight, and you measure from the mid-sternal notch all the way to the tip of their middle finger. But these are 2 alternatives to standing height, and they're both found to be valid and reliable ways to measure height.
We are measuring calf circumference because it gives us some hints, some information about muscle mass in older populations. In addition, if we don't have the opportunity to get weight or height, it's an option. It's an option to complete the short form without having the BMI.
And we always measure calf circumference in the left leg. And you visually inspect the leg to look to see which would be the widest part of the leg. And then you take your tape measure, make sure you have it in the centimeter side. Place it around the leg. You take the measurement, and I have 34.5 centimeters. And so then I take my pen, I put a little mark on her leg as such, and then I'm going to measure above and below that mark to make sure that I did indeed measure the widest part of her calf. The mini nutritional assessment has been developed to assess nutritional status in older adults across the continuum of care. So it can be used in any setting. You can take the score that a person has while they're in the hospital and continue to monitor them over time with the same tool.
The MNA gives us the opportunity to categorize our patients as being normally nourished, being at risk, or being overtly malnourished. Based on the results of the screen, we have to focus our resources. Of course, you will mainly focus on those that are overtly malnourished, but you have to be also aware of those that are at risk. And in my view, it's time for closer weight monitoring in this population. And you should early start thinking about possible etiologic factors and also think about improving diet or going for supplementation. Don't wait until weight drops. As today, resources and time are limited, the short form is really a powerful tool for nutritional screening. But if there are resources, if there's interest, we can use the full form for the education of nursing staff, education of students, education of physicians. And in my view, the full form is also a very reliable research tool when it comes to categorizing patient population for intervention studies.
Screening for malnutrition is very important in older adults because of the various risk factors that accompany aging. an older adult may not know that they are even at risk for malnutrition.
The MNA is the best tool we currently have because we can apply it very easily, and it's built on a very sound scientific basis, and it really reflects the problems of this population, the elderly.